I would like to welcome to the stage Janine Smith from Health Management Associates. And as I learned last night, she's a prioritized list aficionado. So if you have any questions about the prioritized list, this is the woman you want to talk to. Thank you so much.
And I'm joined today, welcome to everyone, with someone who inherited some of my old job and much more. I'm here with Clare Pierce-Wrobel, who's the Director of Health Policy and Analytics. She has a long past, not that long, coming from the DC world, where she was the Director for Delivery System Reform at the White House Domestic Policy Council. She's worked on policy related to Medicare Advantage, Part D, payment reform. She served as a counselor to the U.S. Department of Human and Health Services, to Secretary Becerra in previous administration, and before that has worked in some nonprofit world with multi-payer value-based payment. And she's been a professor at George Washington University School of Public Health, and has also, I first met her when she was overseeing one of our federal grants, the state innovation model that was at CMMI, the Centers for Medicare and Medicaid, just as I was leaving state service. And she now oversees a vast portfolio of policy work in the Oregon Health Authority, including the Sustainable Healthcare Cost Growth Target Program, the Healthcare Market Oversight Program, and also works with the Marketplace and the Public Employees and Oregon Educators Benefit Board. So she has a lot of tasks, including trying to get the Rural Health Grant in the next 24 hours. So she looks rather calm for that, but so we're just going to have a conversation up here, and then we'll open it up to some questions from all of you in just a few minutes. So, as we all have been watching the news, with the passage of HR 1 on the federal level, Oregon is facing a lot of challenges. It was facing a lot of challenges in healthcare prior to that bill's passage. Can you talk a little bit about how OHA is approaching these changes that lie ahead and are there actually right now?
Absolutely, and thank you so much. It's really a pleasure to be here this morning. And as Janine mentioned, I'm coming up on just 1 year
That's right.
With OHA, and oh boy, what a year it's been in healthcare policy. Thank you. Does this one work? There you go. I mean, I hear that. I was going to say, I've heard that people don't want to hear from OHA as much, so maybe this is something I should be taking personally. But and maybe I'll set it on the other side of this stage. But I'm just pleased to be here. I'll repeat a little bit of that. I was here 1 year ago at this conference that was actually my first week in service at OHA as a new health policy and analytics director. And we have been really since then in a period of flux and change when it comes to healthcare policy. And the House Resolution 1, or the One Big Beautiful Bill Act, is just one of many changes that we're currently grappling with as a state and as a healthcare industry and as a nation. I think to answer the question about how OHA is looking at this, I would say we first have to look at the foundation that we've built. This is a state that has always really valued healthcare access and affordable coverage for people, and we've done a darn good job at that. We have a record 97% health insurance rate. We have 1.4 million people on the Oregon Health Plan, on Medicaid. That's seniors who rely on Medicaid-funded nursing homes, that's caregivers, that's half of all kids in the state. We have 140,000 individuals that enroll in private health insurance on the Oregon Health Insurance Marketplace, and we now have 31,000 enrolled in the Bridge program, OHP Bridge, or the Basic Health Program. So we're starting from that place where the focus has been coverage and access, and underlying that, maybe not as kind of central to how we think about it, but certainly now, is that that's really reduced the administrative burden to get access to healthcare. So it's reduced it on the patient side, having continuous coverage eligibility, for instance, in Medicaid, means that folks aren't needing to pull those papers together, not needing to submit that information other than every 2 years. We are now in a place where that is going away. So some of the protections that we've built into the system purposefully to reduce, again, the administrative burden on the patient side, but frankly on the state as well, we are going to have to think about what it means when those protections go away, and how do we as a state implement those changes in a way that doesn't, or at least minimizes, I won't overstate it, there's some of this that we won't really be able to mitigate fully, but we want to make sure that that's not going away, and that it's not creating undue burden on enrollees, on those that are seeking health coverage. But there are some key ways that it will. I think the first will be, as I alluded to, Medicaid eligibility, and specifically the enrollment frequency. So whereas now we have 2 years of continuous coverage, we'll be switching to 6 months, every 6 months for the Medicaid expansion population. And again, as I think about that as a state administrator, we need to now, have 4 times as much capacity at the state to manage that. And we now are expecting folks to have to 4 times as often interact with us to get access to coverage that they are eligible for. I think the second key area that will be a change and a systems requirement for the state will be work requirements. You'll hear more today from my colleague and fantastic deputy director of our Medicaid program, Vivian Levy, and we'll talk more about that. But that's another 500,000 people that we expect will need to provide and will be providing more information and be subject to the work requirements. The third key area that we're preparing for is around how Medicaid is financed. So we use and have used provider taxes as a mechanism for financing Medicaid in the state. That's going away, at least the way that we have relied on it in the past. And that's going to mean about a $12 billion hit to the Medicaid program and how we finance that in the state. And so that's another area where there will need to be lots of conversations about how to address that gap. And then finally, while it's not directly a part of, for instance, HR 1, it's certainly a part of the conversation right now, which is the expiration of the enhanced premium tax credits. So should those expire, if Congress doesn't take action at the end of this year, we are expecting that everyone who receives financial assistance on the marketplace, which is 80% of that 140,000 I mentioned, will see increased premiums this coming year. And that will really be much more extreme for folks that are over 400% of the federal poverty level. So for folks between 200 and 400%, we're expecting somewhere between $90 and $160 increases, but that goes up much further for folks above 400%, and also for folks in rural areas, older adults in rural areas, and younger enrollees in urban areas are expected to feel that most acutely. So again, these are all of the things that we are thinking about and trying to, at the heart of it, keep patients and the people that we serve at the center of how we're building our systems and thinking about how we can provide that support going forward. Because if people are experiencing, whether it's a health crisis or frankly just a chronic disease that they're trying to manage, really the last thing you need is more complexity in the system. And I think about from my own family, our experience when my aunt, my godmother, lost her job in the recession in 2008. This was before, I'm from Michigan, this was before Medicaid expansion in Michigan was a reality that came 6 years later. And she was not eligible for Medicaid when she lost her job. And she spent hours traveling to where she could find part-time work, 3 hours of commuting a day. She also decided to go back to school to take training. And so really these were hours in her day that she was already trying to, quote, do the right thing, find work, educate herself. And during that time, she did not have health insurance. She did not get preventative care and checkups. And she was diagnosed finally, when she finally went into the doctor with stage 4 ovarian cancer. And I took her to the hospital the day that she died. 6 months later. And that is the kind of story that I think about, that we don't want anyone to go through that situation. We don't want anyone to be delaying care, and we don't want anyone to be losing their loved ones because of paperwork. And that's the kind of person that I keep in the front of my mind every day when we think about building the systems and responding to the changes that are coming to the state and to the rest of the country.
Do you think that the bridge plan is going to be able to continue as is to help fill some of those gaps?
I think absolutely. We will continue to look at every opportunity to ensure that we're bridging those gaps, no pun intended, but utilizing the federal policy levers that do remain to be able to ensure that, especially for those populations where we see the greatest churn, folks that have incomes that fluctuate, where they're potentially falling off of Medicaid eligibility because incomes are too high, but too low to actually be eligible for marketplace subsidies. Like, that is the population that the Bridge program is intended to target. But the reality is that there are also changes to marketplace eligibility that are a part of HR 1 as well, meaning that the state will have less, essentially receive less income to be able to support those individuals who are no longer eligible for marketplace subsidies, because that is how we finance the program. So there will be some, again, cuts around the edges there, but we do absolutely see that as a key part of the safety net that we can maintain in the state.
And how has the Health Authority been working with its multitude of partners to try to see what changes, what flexibility potentially can be used, and a direction to guide your planning?
So I think the partnerships that we've built, especially through public health unwinding, are essential here. We're looking at that as really essentially a gold standard for how the public and private sector can partner together to ensure that information is being shared, communications are getting to who they need to at the community level. And I think that is really where we will continue to rely on community partners in this effort. I think our focus at this point has been to communicate as much as possible about what we know and what we don't know, what still needs to be developed and discovered. There's a lot of the law that will rely on interpretation by CMS through guidance and rulemaking. I think a perfect example of that is with Medicaid work requirements. Those are supposed to go into effect at the end of next year, December 31st. Rulemaking, CMS doesn't need to complete rulemaking until June. So we will have 6 months to understand the rules for implementing probably one of the largest systems undertaking, not to mention the operations and communications that will need to accompany that. So we're really in a place where we don't have any option other than to partner with communities to make sure this is as smooth as possible, as I mentioned, to be able to minimize the disruptions for beneficiaries and those that, again, continue to be eligible for Medicaid, but will have to go through many, many more hoops to prove that they are.
And I mean, it's a tough time. I know I started in state government 25 years ago, where we had deep budget cuts, had to start to prioritize what we could cover, what we couldn't cover. It's, of course, rather depressing in my golden years to be having all that unraveled. But access is really key and important to the Oregonians. I know, as working in community health center, how challenging it is to get folks in, to get their, so getting them to renew every 6 months is going to be quite an undertaking.
Absolutely, all hands on deck effort.
Yeah, both at the provider side as well as the partners and the authority.
Absolutely.
Yeah, I know you've been slaving away for the last few weeks on the rural health grant application. Can you share with us kind of the general direction of what's in that? I know it'll be eventually made public once it ever gets officially submitted, because having submitted many grants, and you on the other end having accepted many grants, you know the glitches, so you've already started as early as yesterday just to work on the submission process.
That's absolutely right, and I think doing so during a federal shutdown adds another level of intrigue into whether the systems will actually work. So just for background, the Rural Health Transformation Program was authorized under HR 1. It's a $50 billion appropriation for 5 years to all 50 states. And the expectation is that half of those awards will be split evenly to all 50 states that apply and who are accepted for an award and meet the minimum criteria. And the other half will be determined by CMS according to the Notice of Funding Opportunity criteria that they published on September 15th. And they graciously gave us 6 weeks to pull together quite a complex application. So our team, as you mentioned, is, and as you know personally, is fantastic. Has been working around the clock to make sure that we are submitting a competitive application, but more importantly, one that has been informed by community input. So even before the Notice of Funding Opportunity was available, we started with public comment opportunities, meeting with community about what Oregonians and what rural Oregon wants to see from an opportunity like this. We hosted public forums, we hosted tribal consultation, and we put together an application that's responsive both to the challenges that we heard are most acute in rural Oregon and the solutions that are most promising while fitting into and aligning with the goals that CMS has put forward. And so we are, as you said, submitting the application by the deadline tomorrow, and we are expecting to, thank you. And thank you again to our fantastic team. Steph Jerem, who's our Director of Health Policy in the room here, has been leading that effort for OHA. And again, can't say enough about being in partnership with public servants, especially during a time when public servants are being denigrated in multiple different to be able to work with a team that is as committed, and I wish that everyone could see that and see what value that we have in Oregon in supporting folks like that. So I think our goal, again, is to receive that award. We expect to hear from the federal government by December 31st. They gave us a quick deadline. They also gave themselves a quick deadline to turn that around for a award that would start if we receive it on January 1st. So we have designed a proposal that would really hit the ground running on January 1, being able to invest in essentially 2 different phases across 5 different initiatives. So I'll speak to the initiatives first. We are looking to fund initiatives that address healthy communities and prevention, recognizing that access to primary care and prevention and increased access points in rural communities are really critical to address the disproportionate burden of chronic disease, of behavioral health issues, and other needs in rural communities. The second initiative will be, well, how do we do that? We really need to increase workforce, both workforce recruitment and retention in rural communities, and to make rural communities a place where providers want to train, to practice, and to live. And that is where we will be looking to fund either from the pipeline, early pipeline programs, residency programs, and other training programs that can support those efforts. Third, we plan to invest in data and technology, recognizing, and we heard from public feedback, and CMS has really emphasized the importance of this in the Notice of Funding Opportunity as well, also called a NOFO, in case I slip into acronyms. The technology component here, I think, is really critical to think about, both from how do rural health systems and communities provide services efficiently, but how are we able to use technology to force multiply the limited workforce that is there? How do we think about telehealth more as a comprehensive component of the healthcare fabric, telementoring for that training component, et cetera. And then fourth, and really part of, I think, the key to sustaining these efforts, recognizing again that this is only a 5-year program, that this is only a small portion of the funds that we expect to lose. So if we are getting a baseline of $500 million over 5 years and maybe a little more, knock on, oh, there's just glass here. But if we are able to receive additional funding based on the merits and the technical factors in the application, then we'd like to do more with that as well. But I previously said we're expecting about $12 billion less to the Medicaid system over that same period of time, and so it's not going to fill the full gap. So when we think about sustainability, the fourth area is really focused around regional collaboration, ensuring that we are looking for, again, at the community level, for those collaboratives, some that have already started, which we'd like to expand and accelerate, and building others where they don't currently exist, to be thinking about essentially right-sizing care in those communities, sharing resources in a new way, perhaps sharing technology purchases in a new way, and being really laser-focused on how those changes can be sustained even after this funding goes away. And then finally, we are proposing a set-aside for a tribal initiative that will be led by the 9 tribes, federally recognized tribes of Oregon. That is something that we are committed to, that the Governor Kotek is committed to when it comes to supporting tribal sovereignty and self-governance. So the tribes will be leading that initiative directly. And as I mentioned, my last piece that I'll say is that from a timeline perspective, we are looking at this 5-year program across 2 phases. So I would say, or phase 0 has really been ramping up the planning and hearing from the community and being able to see where there might be opportunities to, again, fund ready-to-go projects, shovel-ready, however you want to call it.
Need to get that money out.
We need to get that money out the door.
You lose it if you don't get it out.
Exactly. Yes, we have a...
Usual.
It is, right, from a federal grant perspective. Just to reiterate what Janine just said, there's some very interesting parameters in this funding where typically in a cooperative agreement, the state would be able to carry over funding that's not used in one year to the next year. That doesn't exist here. So we are going to be, first of all, subject to potentially having funding clawed back if we don't meet the specific milestones of the grant. We are also not able to carry over that funding from year over year. Although if we make push out awards, those awardees would be able to use the funds for 2 years. So there's some of those, again, technicalities that we're baking into how we think about this. But that first year is only 9 months. So this is on a federal fiscal year, which means it's October to September. So that first year, we are really going to be focused on what we're calling catalyst awards and direct impact awards. Direct impact means areas that we already know there are programs in place, residency, additional residency training slots. That would be a great example. Or catalyst awards, where organizations have something that's really ready to go. They just need the funding for it. And so those will be the focus in the first round, as well as starting to support that technical assistance for regional collaboratives to get up and running. And the second phase will be then trying to say, how do we build on that foundation to move and advance further towards sustainability? So we'll be incentivizing regional collaboratives or consortia to apply together for phase 2 awards, either to continue the projects that were funded as a direct impact or catalyst award in phase 1, but really looking again for what those creative collaborations and networks will look like to ensure that funds that are used in years 3 through 5 are able to be, those projects are able to be sustained over the period after the award, which is a critical part of the CMS application that we will be submitting. So that's kind of the timeline, and really more to come. And I think this is, again, one of the opportunities that we are making sure that we absolutely don't pass by to address what will be challenges that are faced across the state when it comes to the federal changes in the coming years, what will be particularly acute in rural communities.
Before we go to questions, I did want to spend just a few minutes on affordability. Oregon has certainly been a leader in one of the few states that has the sustainable cost trend cap. It's also had a market oversight program. I know the policy board is putting affordability as a key priority as it moves into the next year or so. Can you talk a little bit about some of these efforts? Because ultimately, if you have less money, you have to use it more efficiently. So affordability is key.
Absolutely. I couldn't have said it better. I think that affordability is front of mind probably for everyone in this room. We know that the healthcare dollar really can't be stretched much further if we have healthcare costs that are exceeding wages. The math isn't mathing. And we know that that's not working for providers, it's not working for payers, it's not working for patients, and it's not working for purchasers. I think about some of the stats just around small businesses and the fact that a third of small businesses are dropping their health coverage every year. Because of being priced out of the market. And so if we are not creating opportunities for and systems that are addressing excess cost growth such that everyone is being priced out of the market and frankly businesses are being priced out of the market, then that becomes and is a broader economic issue that needs to be addressed. And so I think the charge that the Oregon Health Policy Board has made to the new Committee on Healthcare Affordability is to get recommendations on what are some of those cost containment or cost reduction policies that could really get at the heart of the issue. And there might also be recommendations around more short-term fixes. And that's really kind of the two sides of this coin here. There has to be more short-term solutions and also longer-term solutions to address the underlying issues. I was thinking about how it really is, I was going to say there's like the Band-Aid versus the longer-term cure, but has anyone heard about the skin substitute issue that is going on in the Medicare program right now? I was going to use that as a better analogy for Band-Aids, because skin substitutes, which are incredibly expensive now in the Medicare program, have seen increases in utilization and price, or just a kind of textbook case of fraud. And the issue there is that skin substitutes are meant to be a temporary solution for things like diabetic foot ulcers. But you know what the actual treatment is for that would be treating the underlying diabetes. And if you are just replacing skin substitutes and basically having a continued open wound and not treating the underlying condition, you're just going to continue to have to pay for more skin substitutes. And I think that to me is kind of similar to some of the, for instance, affordability levers that we pulled at the federal level. So in my most recent position, I was leading the implementation of the Inflation Reduction Act, including all of the prescription drug pricing provisions, such as the Medicare Drug Price Negotiation Program, implementing the $2,000 out-of-pocket cap in Medicare, and the $35 cap on insulin out-of-pocket. And that's a place where, on one hand, you absolutely want to make sure that patients that need insulin are able to get it at a reasonable cost out of pocket, that they're not going without a preventive service and treatment that we know is evidence-based and will help to manage what could otherwise be expensive complications. But if we are capping that on one side, but not addressing the underlying cost, and Medicare is still paying $400 for a vial of insulin that costs $10 to make, we're not solving the underlying problem. And so I think that's where the Affordability Committee is looking at both sides of that coin. We know that folks are still experiencing undue medical debt, have medical bankruptcies. We need to address that piece of it. But we also need to be looking at the other factors like consolidation and things that are leading into a more complex but expensive healthcare system. And I think to just speak for a moment on some of the tools that you mentioned that OHA and the state of Oregon are using. The Sustainable Cost Growth Target is one of those. That is a program that's in place to do a few different things. And the one, I think, core of that is better transparency. So through the Cost Growth Target program, which states that healthcare costs should not exceed 3.4% year over year, and healthcare spending in the state should not exceed that amount. We at the state collect data from payers and providers and evaluate whether it meets that target or not within statistical significance. And if it doesn't meet that target within that range, we then ask for more information from those providers and payers to determine, was the cost reasonable? Because there are certainly cost growth that is reasonable. There are parts of the healthcare system that have been woefully underfunded, while others have had more resources. And so it is not enough to just look at that particular number and that particular target. It's really about getting under the hood there. And some of the reasons that we look at and that are codified in our regulations include things like, were there changes at the federal level or the state level that may have influenced the cost growth that we're seeing? Are there workforce costs that are increasing, frontline staff workforce costs? We'll look at that. Are there high cost outliers? So for instance, a practice that's going to see one patient that might have millions of dollars in cost that year and would put them over the target, that's something that we would look at. And then drug costs as well. There are new drugs that are coming out of the market, cell and gene therapies, that we know are something that we want to bring under our accountability models, but that are frankly out of the control a lot of times of provider practices and payers. And so once it goes through that filter, then we have a pretty good sense of whether the cost growth is reasonable or not. And we make those determinations, and we make those determinations public. And we just made the most recent round of determinations this past week. So I think that's a place where we can say, here are, in both our reports that are broadly looking at state cost trends under that program, as well as in the particular cases, what needs to change. And this is the first year that we will be asking for those providers and payers that have exceeded the cost growth without an acceptable reason to submit a performance improvement plan to OHA, and so that we can work together on really addressing what the underlying cost drivers are that are leading to that excess cost growth. So I think that's part of the way that we are really working in partnership, both by providing that transparency to the community, to policymakers, and frankly back to the entities themselves to say, compared to your peers, here is where you are not meeting the mark, and let's work together to get to a better place.
Great. We'll open it up for some questions. There's a couple of folks in the audience with microphones. If you can, I think there's, she's back there, and I'm not sure if there's one over there. So if you want to ask a question of Clare somebody right there.
Hello. 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 Yeah. Thank you for opening up to questions. I have sort of a longer question, but
Can you introduce yourself?
Oh, yeah, totally. My name's Colin Stackhouse, and I work with Healthcare for All Oregon. And this question is about like hope and hurdles. Both of you are so plugged into the challenges that we're seeing here in Oregon, and so this question sort of is moving beyond our current crisis of today towards hopefully something better in the future. Both of you know about the state of Oregon's Universal Health Plan Governance Board, and so since you know about that, you know that in 2026 we'll be receiving our completed transition plan from the governance board. We can expect a vote likely in 2028 to see if the state wants to move to a universal healthcare system, and then in 2030 is the discussion of that potential transition, which is 5 short years from now. So it's going to be a long haul, certainly, but I'm very curious, what are your hopes if Oregon does vote to make this transition to try to implement a universal healthcare system? What do you hope you could see changing in your day-to-day and in the care for Oregonians? And then what do you think, if you could name only one huge hurdle, what do you see as the biggest hurdle to get us towards a universal healthcare system in Oregon?
Well, with some disclosure, I've done some staff work to support the current Universal Governing Board, as well as both at my time at the state and since at HMA, also have supported various other versions of discussion, earlier discussions of this. I think there are a lot of challenges to achieving universal coverage due to, at the moment, some of the changes on the federal level will really impact the availability of funding for it, as well as flexibility, especially in the Medicare side of it. There's only a couple other states that have really started down this road. Some have carved out the Medicare population in order to skip that challenge. But I think it's a matter of really trying to, as Oregon always does, and having come into government when we were going around the state to get input that, and when I was in training, and early practice to develop the prioritized list and the original Oregon Health Plan, it really took sort of the whole community to work together to decide if that's what they want, direction they wanted to go. And I think this would also, it's going to be that community collaboration and thinking it through. There's pros and cons. There's winners and losers, so to speak, in the shifts that will happen. Health plans might not exist the way they do now, depending on how it's structured. So I think it would be great to see it happen from a provider perspective. It would be a bit easier to have 1 or 2 places to bill. And if it would increase access, I think that would be the 2 things you would like to see if it was successful.
I think I would just add on to that, in addition to my thanks, Janine, to continue to learn from you and your experience in this area. But I think under the current legislation, the role of OHA anyway is to support the governance board in thinking through what those federal authorities are in a much more tactical way, and to provide that to the governance board to consider as they're developing their recommendations. And so, should those recommendations go forward and the legislature take additional action, I, personally see that that's where the key challenges will be, is pulling each of those federal policy levers, because there's a level of complexity to just one piece of this puzzle, right? Just negotiating a 1332 Affordable Care Act waiver, just negotiating an 1115 Medicaid waiver, and all of the other pieces that would need to come together. But as I mentioned, we have the best team in state governments, so I don't doubt that if given the task, our team would be able to succeed in that. And then I think the key benefit I would see again, reflecting on what the current state of affairs is, and what keeps me up at night, again, is that complexity, that we are just in an incredibly complex system, such that it seems like we can't necessarily get our hands around all of the challenges that are facing the healthcare system in a way that makes it make sense for consumers, for taxpayers, for a state agency that's trying to be a good fiscal steward of the public dollar. And so I think any opportunity that we have to reduce that complexity and administrative burden across the board is a good thing in my mind.
I see one hand up over there.
Hi, I have a quick question about the pharmacy benefits. In your opinion, like, is there a potential directions heading to integrated pharmacy benefit in terms of a PBM due to the rebate inflation and also many legislative changes to promote affordabilities? Thank you.
I would say that in terms of looking at options to address cost growth in the pharmacy benefit, not just for the Medicaid program, but I would say also for our state employees, marketplace, and private insurers, I think we do need to be looking at all options, and really are looking at all options for how to do so, whether that's moving in a direction of having a more unified drug list, or for instance, as we have for our state employee plans, moving to a nonprofit PBM model through the Oregon Prescription Drug Program and ArrayRx, such that we have the transparency in place to ensure that we are getting fully getting the benefit of pass-through rebates from our PBM, so that we can ultimately drive down the costs and premiums. And so I think all of those options are on the table, and continue to look for input from the community about how that would work, what challenges that might pose, and what the best direction is to move forward.
Well, I think our little time clock just ran out up here, so I want to give a warm thanks to Claire for all of her time and energy and the great work she's doing.